Hi medicos, today we are going to study about the solar joint. Solar joint is an important essay in the upper limb. It is otherwise known as the glenohumeral joint. Actually, it is a joint between the head of humerus and glenoid cavity of scapula. This is the head of humerus. This is the glenoid cavity of scapula. I am showing it in a rough manner. Okay, this is the head of humerus. This is the glenoid cavity of scapula. The joint between these two articulating surfaces is solar joint. Actually, it is the most movable joint and least stable joint. Due to its least stability, dislocations are common in solar joint. It is a synovial type of joint, okay, especially the ball and socket type of joint. This is the ball and the socket type of solar joint. Okay, in this video, we will study about the solar joint and its articulating surfaces, its ligaments, and bursa, also the relations of solar joint, that is the anterior, superior, inferior, and posterior aspects. Also the factors maintaining the stability of solar joint and movements of solar joint. At last, the clinical aspects of solar joint. Okay, let's start. Coming to the articular surface of solar joint, as I said earlier, it includes the head of humerus and glenoid cavity of scapula. This is the head of humerus, which is large, and glenoid cavity of scapula. Actually, the glenoid cavity is shallow, but it is deepened by glenoid labrum. I will show it in a lateral view. Okay. Think of lateral view of solar joint, removing the humerus. Okay. This is the glenoid cavity of scapula. Okay. Around it, the fibrocartilaginous ring is formed, which actually deepens the glenoid cavity. This fibrocartilaginous ring is nothing but the glenoid labrum. It deepens the glenoid cavity for easy articulation of head of humerus into the glenoid cavity. This is fibrocartilaginous ring, that is glenoid labrum. Okay, there are four main ligaments and one accessory ligament. The four main ligaments are capsular ligament or joint capsule, and another one is glenohumeral ligament. The third one is coracohumeral ligament, and the fourth one is transverse humeral ligament. And the one accessory ligament is coracoacromial ligament. Okay, at first we will study about the capsular ligament, next glenohumeral, coracohumeral, and transverse ligaments. Okay, coming to the capsular ligament of solar joint, it is actually a thin fibrous layer covering the capsule of glenohumeral joint. Okay, it extends medially and laterally. Medially, it attaches to the glenoid cavity margins beyond the glenoid labrum. It also extends beyond the supraglenoid tubercle, enclosing the biceps brachii tendon. Laterally, it is attached to the anatomical neck of humerus. Inferiorly, it extends 1.5 centimeters below up to the surgical neck of humerus. Okay. Medially up to the glenoid cavity, laterally up to the anatomical neck of humerus, and inferiorly it extends 1.5 centimeters below, that is surgical neck of humerus. I will show in a diagram. This is the joint capsule. Medially it is attached to the margins of glenoid cavity, laterally to the anatomical neck of humerus. Inferiorly it is extending beyond the surgical neck of humerus. This is the joint capsule. The joint capsule inner membrane is lined with the synovial membrane. This is the inner membrane which is lined by the synovial membrane. Okay, this is the interior of synovial membrane, that is interior of joint capsule. This is the synovial membrane lining the joint capsule. Okay, the synovial membrane forms the tubular sheath here on the biceps brachydactyl. This is biceps brachydactyl. Okay, it also has communications with subscapular bursa and infraspinatus bursa. Okay, it has three apertures. The joint capsule has three apertures. Three apertures means three openings. They are first, as I said, opening for BPT, that is biceps brachydactyl, that is tubular sheath. Another opening is, this is coracoid process, we all know, anterior to it and also inferior to it, anterior inferior. That is here. There is opening of joint capsule communicating with the subscapular bursa. So aperture for communicating with the subscapular bursa. Subscapular bursa. And third opening is posteriorly. We can't see here. It is present posteriorly to allow communications for the infraspinatus bursa. Glenohumeral ligament. It is actually present in the anterior aspect of fibrous capsule. It is only visible through the interior part of fibrous capsule. Okay. It exists as three thickenings. They are the superior glenohumeral ligament, the middle glenohumeral ligament, the inferior glenohumeral ligament. Okay. The superior and middle glenohumeral ligament are of clinical importance as they are reason for anterior dislocation of shoulder joint. The third ligament is the coracohumeral ligament. It actually extends from the base of coracoid process to anterior aspect of greater tubercle. I will show in diagram. This is the base of coracoid process. From here, the ligament extends up to the anterior aspect of greater tubercle. This is coracohumeral ligament. Coming to the fourth ligament, that is transverse humeral ligament. It forms a bridge between two tubercles. This is lesser tubercle. This is greater tubercle. The bridge formed between these two tubercle is transverse humeral ligament. It converts the biceptal groove into the biceptal canal through which the biceps brachydactyl goes. The accessory ligament of shoulder joint is coracoacromial ligament. Okay, it extends between the coracoid process and acromion process. This is the coracoid process. This is the acromion process. The extended ligament between them is coracoacromial ligament. Okay, it gives protection on the superior side, superior aspect. Coming to the bursa of shoulder joint, the shoulder joint contains three main bursa. They are subscapular bursa. The second one is subacromial bursa, and the third one is infraspinatus bursa. Coming to the subscapular bursa, here it is. First of all, this diagram is of sagittal section of shoulder joint, that is lateral view. Okay, this is subscapular bursa. It is exactly beneath the subscapularis muscle. This bursa reduces the friction of subscapular bursa on neck of scapula. Okay, it reduces the friction of this muscle. Okay, the second one is subacromial bursa. This is subacromial bursa. It is exactly beneath the acromion process or coracoacromial ligament. It often extends downwards beneath the deltoid muscle. This is deltoid muscle. Extend beneath, downwards, so called subdeltoid bursa. It has two names, either subdeltoid bursa or subacromial bursa, and it is the largest bursa in the body. Okay, infraspinatus bursa. That one is, here is the infraspinatus bursa. It is between the infraspinatus muscle and posterolateral aspect of joint capsule. This is joint capsule. This is infraspinatus muscle. This is infraspinatus bursa. Okay, here comes the bursa.
Coming to the relations of shoulder joint. In shoulder joint, we can see the superior, inferior, posterior, and anterior relations. This is the lateral view of shoulder joint. Okay. In this diagram, we can see this is the superior aspect, inferior aspect, anterior aspect, and posterior aspect. Okay. Let us see one by one. Coming to the superior aspect. In superior aspect, we can see the coracoacromial arch. I will explain it. This is the acromion process of scapula. This is the coracoid process of scapula. The ligament between them is coracoacromial ligament. It is the accessory ligament, as I told earlier. These three structures form the coracoacromial arch. Okay. It is also a factor giving stability to the shoulder joint. And the second one is, we can see the subacromial bursa. And third, we can see the supraspinatus muscle. Here is the supraspinatus muscle. By the diagram itself, you can recognize all the relations of shoulder joint. Okay, here we can see the deltoid muscle. This is deltoid muscle. Okay, I am saying it very slowly. If you want, you can increase the speed. Okay, coming to the inferior aspect. This is the inferior aspect. Okay, here we can see the axillary nerve, the posterior circumflex humeral artery. This is the long head of triceps. Okay, these three structures form the inferior aspect of shoulder joint. Okay, teres major. Inferior. Here we can see long head of triceps. And as I told earlier, axillary nerve and an artery, that is the posterior circumflex humeral artery. Okay, coming to the anterior aspect of shoulder joint, anterior relations, we will see. This is the anterior relations. Here we can see the subscapularis muscle, the subscapular bursa, the tendons of coracobrachialis and the shoulder of triceps, then the deltoid muscle. All of you understood, I think. Okay.
As I told earlier, subscapularis muscle. Subscapularis bursa to coracobrachialis and biceps sternum. This is coracobrachialis and biceps sternum. Here, subscapularis muscle, subscapular bursa, and deltoid muscle. Coming to the last posterior aspect of shoulder joint. Okay, in posterior aspect, we can see muscles, only three muscles. They are infraspinatus. This is infraspinatus muscle and deltoid muscle, and also teres minor muscle. These three muscles. Okay, infraspinatus, teres minor, and deltoid muscle. These all structures form the relations of shoulder joint. These are superior, inferior, anterior, and posterior. Okay, by the diagram itself, you can learn all the aspects. Coming to the arterial supply of shoulder joint, the glenohumeral joint is supplied by the three arteries, mainly by three arteries. They are three types, anterior and posterior circumflex humeral artery. As they are supplying around the humerus, they are called humeral arteries. Okay. Another one is suprascapular artery. Third one is subscapular. It's easy to remember. Okay. Coming to the nerve supply. Nerve supply of shoulder joint. It is done by mainly by three nerves. They are SAM. S for suprascapular nerve. A for axillary nerve. And M for musculocutaneous nerve. You will learn this in brachial plexus. These two. And also this. Coming to the factors related to stability of shoulder joint. There are four main factors. They are rotatory cuff muscles. And second one is, as I told earlier, coracoacromial arch. And the third one is long head of biceps tendon. And the fourth one is glenoid labrum. Okay. Coming to the rotatory cuff muscles. Okay. Take the lateral view of shoulder joint. This is the glenoid cavity. Here four muscles are involved. Okay. They are six muscles. SITS. Okay. S for supraspinatus, I for infraspinatus, T for teres minor, and S for subscapularis muscle. These four muscles are around the glenoid cavity, around the shoulder joint, help the humerus to get attached to the glenoid cavity and help in rotatory motion. Okay. Think this is the glenoid cavity. This is the glenoid cavity. Okay. I said the four muscles. This is the supraspinatus muscle, infraspinatus muscle, teres minor muscle, subscapularis muscle. Okay, these four muscles give stability to the shoulder joint. Okay, this is the coracoid. Sorry, this is the coracoid process of scapula. This is the acromion process, coracoid process, acromion process. The ligament between these two is coracoacromion ligament. These three structures, acromion process, coracoacromion ligament, coracoid process. These three structures form coracoacromion arch. Okay, it helps in prevention of upward dislocation of shoulder joint. Okay, understood. Next one is the long head of biceps. Think this is the head of humerus. Okay, the long head of biceps tendon actually travels on the head of humerus through biceptal groove, like this. Here is the biceptal groove. From this it will travel like this. It will travel. Okay, this is long head of biceps tendon. It prevents upward dislocation. This is the glenoid cavity. Around glenoid cavity, we can see the fibrocartilaginous ring, that is glenoid labrum. It actually deepens the glenoid cavity for easy articulation of head of humerus. If the depth is more, the stability will be more. So glenoid labrum helps in the stability of shoulder joint. I hope all of you understood.
Coming to the movements of shoulder joint. Okay, the shoulder joint has more freedom of mobility. Okay, due to its laxity of joint capsule. Laxity means looseness of joint capsule. Also, the articulating surfaces. The articulating surfaces are head of humerus and joint cavity of scapula. Okay, it is large. Head is large, while the joint cavity is small and shallow. Due to these differences, there is more freedom of mobility. Okay, here we can see the movements like flexion, extension, abduction, adduction, and the medial rotation, lateral rotation, also circumduction.
Here is the diagrammatical representation of movements of shoulder joint. In flexion, the arm moves forwards and medially. Medially means near to the body. In extension, the arm moves backwards and laterally. Laterally means away from the body. And other movements are abduction and adduction. Let's see here. In adduction, the arm moves anterolaterally like this. Anterolaterally away from the body. In adduction, the arm moves posteriorly towards the body. Okay, this is adduction. This is abduction. Okay, in medial rotation, lateral rotation. It is demonstrated well in mid-flexed elbow. Sorry, this is mid-flexed elbow. In medial rotation, the arm rotates medially, that is towards the body. In lateral rotation, the arm rotates laterally, that is away from the body. Another movement is circumduction. Circumduction is nothing but movement of combination of flexion abduction, extension, adduction, or reverse. These four movements done in one time is circumduction.
Coming to
Okay.
the clinical correlations of shoulder joint. Okay. The first one is dislocation of shoulder joint. In this condition, due to dislocation of shoulder joint, it majorly occurs in inferior aspect because there is no stability factor maintaining the inferior stability of shoulder joint. So, if inferior dislocation of shoulder joint occurs, axillary nerve will get damaged. Remember this axillary nerve, okay? And the second one is shoulder tip pain. It is a type of preferred pain you will study in physiology, okay? And the third one is frozen shoulder. In this condition, the joint capsule gets shrunken. Due to its shrinkage, all the movements of the shoulder gets limited uniformly, okay? Movements get limited. The fourth one is rotatory or rotator cuff disorder. In present generation, it is a common reason for shoulder pain. In rotator cuff disorder, the sixth muscle gets damaged due to over deposition of calcium, and also it is common in 50 years of age in males. They get pain when they abduct their arms. Okay, these are the clinical correlations of shoulder joint. The essay is completed. Okay, thank you.